from the flanged and the round back 40s and 45s to the kind of highly modular components that we now play about with today, as we've seen through the whole day. Indeed, there has been a desire in hip surgery, both from patient expectations point of view and even from the point of us marketing ourselves to our patients. We want to reduce the dislocation rate, we want to increase the hip range of motion, and most importantly, we want to optimize the soft tissue balancing. It's no more about doing a THR. We want the optimal result. We want to personalize our hips for our patients today. So modularity has indeed had a huge role to play over here. Advantages of modularity at the head-neck junction have been intraoperative flexibility, the ability to change only the femoral head later on if required. You could reproduce the anatomy perfectly. You could minimize dislocations. You could adjust your anteversions. You can alter your neck length scenario and also adjust the offsets more efficiently for the patient. Question is, are we carrying modularity too far? Are we trying to personalize our hips just too much for our patients, more than we should be? Are we inviting trouble over here? I'm sure you remember the story of 5 or 10 years back when somebody had come out with highly modular, ultra-modular components which are modular at the neck and the heads, and these led to complications such as at the neck-stem interface, such as eccentric loading, fretting, corrosion, metallosis, fracture, and dissociation, and those components now have clearly been given up. So too much of modularity also leads to problems such as trunnionosis and metallosis. So taper corrosion and fretting at modular junctions has been known for years. It's now again coming up into play, and 2 to 4% of revision hip surgery today is due to implant corrosion indeed. And even though it's more often seen in the large head metal-on-metal hip replacements, which we no longer perform, but many of these are still floating about today in an unrevised state, and you need to be aware about those should they come up for revision at some point. Also, you can see it in the larger head metal on polys, 36 heads and above, and also in 28 millimeter ball heads, you can see corrosions. Indeed, it's less with the ceramic heads or minimal with ceramic heads. So is THR a victim of its own success, you may wish to ask? And yes, we have been trumped yet again in a way. So innovation drives advancement, but it's not immune to failure. You remember the story of the Concorde, successful for a while and then was withdrawn from the market. So the introduction of a Morse taper junction, or the cone within a cone concept, indeed has been what we've been using in terms of modularity, which is the taper concept in the THR. So a taper Morse works by producing a frictional force. When you bang the head onto that taper, you're producing a frictional force, and that keeps these two components together. There's no screw or anything to hold it together, and that frictional force is resisting what's happening in the body for 15, 20, or 25 years thereafter. It's resisting all those torsional and axial forces which are being created at the modular junction. So you need a perfect taper, you need an optimal taper design to produce good contact along the taper. And the success of that taper is going to depend on the design of the taper, the length of the taper, the thickness of the taper, and good mating between the male and female components of the taper. Trunnionosis basically is defined as wear of that femoral head-neck interface. It's a type of wearing out of this junction which is bound to happen over a period of time and years. Because there is going to be micromotion over a period of years. This happens over millions and millions of cycles, and some metal debris will get released into the joint. That will then create an inflammatory response, which will give rise to some pain and eventually loosening of the implant itself over years. But the problem is that we use dissimilar materials within the joint. We use titanium for uncemented stems, and then we use cobalt chrome as a onto the head. So effectively we mixed and matched over here. And when you mix and match, what you've done is you created a battery system over here with starting electron transfer, and therefore you started chemical corrosion. On the other hand, there's also crevice corrosion starting at the same time, and this is what gives rise to trunnionosis, which is shown in the diagram over here. The etiology, what causes it, is patient-related factors such as high body weight, activity level, impact activity, metal sensitivity, or a younger age of patients, or they could be implant-related factors such as incomplete junction fitting, more so in higher offset stems, a metallurgy mismatch, a larger head size, smaller taper dimensions, or stems which are implanted into varus are more prone to trunnionosis. In the larger heads over 36 millimeters, such as 40 millimeter heads, which we once used, you get mechanically associated crevice corrosion at these junctions, and this can give rise to local adverse tissue reactions. Lavarina has shown beautifully some years ago that as the head size increases from 28 to 32 to 36 and 40, the stress on the trunnion goes up exponentially, and that's precisely the reason why we no longer use heads over 36 millimeters. This is an example of one of our extra large and metal-on-metal hip replacements, which gave rise to phenomenal trunnionosis, and that's the reason why, and that's because of excessive frictional torque at the taper, and that's the reason why these are no longer used in current practice. How does one diagnose Trunnionosis? How do these patients present? Well, they present with persistent pain, swelling or instability even when the hip looks bang on normal on an x-ray, and you wonder why they're having a problem. And once you rule out infection, you got to think of Trunnionosis. You may need to do cross-sectional imaging such as a mass MRI. You can do whole blood metal ion levels such as cobalt and chromium. Cobalt more than 4, chromium more than 2 could be diagnostic, and often cobalt is twice this level of chromium. X-rays could be normal, or they could show scalloping, bone loss, or periosteal reactions. And in the surgical findings, you can see metal debris, soft tissue masses, or some damage to the abductors. But definitely you got to consider this as a diagnosis in any hip pain where the X-rays look normal. And that's what the surgical findings would look like. Ceramic heads can also lead to corrosion, but very minimal, and it's an inert material, and that's the reason why you want to use ceramics. How does one treat Trunnionosis finally? You go to explore the hip, debride the hip. In case of a well-fixed stem, you can leave the stem alone. You can only remove the femoral head, wash the taper out, clean it with a wet mop, and even clean it with a dry scratch pad, or scratch it with the reverse side of a 22 number blade. Eventually avoid putting a cobalt chrome head back on. Avoid putting a ceramic head directly onto that taper because the taper is damaged and it could lead to ceramic head breakage. You could put a titanium sleeve back on because you get the least Trunnionosis with ceramic, and perform an isolated acetabular liner exchange if the head is, acetabular component is good. What sort of sleeves do you use? You could import bioball sleeves. Previously used delta motion sleeves, which are not available, but nowadays we use Merrill sleeves on well-fixed limbs. The problem is there's not a standardized taper design. All 12-14 stems are not equal. You get more Trunnionosis with the 9-10 or 11-13 taper as compared to the 12-14 taper. Therefore, you need better designs by talking to manufacturers. And the last slide is surgeon factors to minimize Trunnionosis. Never mismatch the head and trunnion of different manufacturers. Keep the trunnion dry before head implantation. Appropriate head impaction is required at a correct angle and force. You need a 4,000 Newton force, 2 blows with a 500-gram hammer. You need to try out the Ceramtech workstation to know what sort of force you need while impacting a head. And quite often the force you need is much more than we use to create an appropriate frictional force to keep the trunnion in good condition, and use the correct appropriate head size, not necessarily that biggest is the best. Thank you for your attention.